Okay, this is going to be the last lecture for the February 8th, 2014 portion of the paramedic refresher for trial fire and rescue. So we're going to go over pre-hospital capnography. It was a lecture I put together several years ago when we first got capnography, actually, for our LIPAC 12s. It's just a good review for those that forget why we use capnography or how we use it and what the intended purpose is and how it works. So why do we use it? That's kind of the main question. Why people, they'll ask, why do we have to use capnography? Can't we use, the colorimetric, or can't we just use pulse oximetry? Like, really, what's the point? And it's very important that we use capnography. It tells us so many different things about our patient that, just our eyes and our ears can't tell us, and definitely gives us a good indication of how our patient is doing. Remember that it provides another measurement in assessing our patients. It gives an objective measurement of our patient's status, shows a graphic picture of our patient's ventilatory status, presents an early warning of the changes in your patient's cardiopulmonary status, supplies important documentation for our patients. Remember that it provides a numeric value of the end-tidal CO2 and also the waveform of the respiration. All right, so what is end-tidal CO2? Remember that breathing is done in waves, that end-tidal CO2 is the amount of CO2 measured at the peak of the wave, and then end-tidal CO2 is actually measured at the nose, mouth, or hub of the ET tube. So, obviously with the hub, that's when we're using the filter line, and then the nose and the mouth, that's why we use the Capno line, or that smart Capno line. Remember that pulse oximetry measures the oxygenation. Capnography measures the ventilation. So what's the difference between oxygenation and ventilation? And remember, pulse oximetry, it goes on their finger, it may go around their toe, it may go, they got the special ones that go across your nose. However, it's only as good as your perfusion if you're oxygenating versus capnography. You can do this on intubated or non-intubated patients. Remember, for colorimetric, it's not out of the question if that's all you have available at the time. You could only use it for intubated patients. You can't use it for just a patient that's, that's sitting there, that's non-intubated. Definitely single use. They're easily impaired by moisture or secretions, so whether it be vomit or whether it be something, they get sodium bicarb or something else on them, it's going to give you bad readings. It's basically going to get on that litmus paper and destroy it. And it says it gives false negatives during cardiac arrest. So the one on the left-hand side is the purple one. That's actually poor, so P for poor. And then on the right-hand side, the yellow, I always say, Y for yellow or yes. So that means you're in the right spot. So if it's yellow, that means yes, you're in the right spot. If it remains purple, that means it's poor, and you're probably not in the right spot if you're trying to use that for a confirmation device. Remember that we cannot use it for children that are less than 33 pounds, and we can only use it on, basically it's in between 33 pounds and below. We can't use it, and they have to be above 33 pounds for the adults. So basically 33 pounds that are cut off. We do have there is a child that goes below 33 pounds and the adult that goes above 33 pounds. So this is an adult one. Once again, remember the child is the actual pediatric one, and that's our cutoff, is at 33 pounds. So numerical value of the end-tidal CO2 and a waveform of the concentration of the carbon dioxide present in the airway. So you can see that's a normal capnography right there. This is somebody with a tension pneumo. I'm sorry, with the normal there, and then that's the tension pneumo. And there's somebody that is, they're actually retaining the carbon dioxide but breathing fairly fast. So remember, we use capnography for both the non-intubated and the intubated patient. It gives us a continuous breath-to-breath monitoring. It equates to basically ECG monitoring in a cardiac patient. remember that we can use low flow technology, and it's accurate in all age groups, regardless of the age. It actually is accurate. For airway, it actually gives us a verification of our endotracheal tube placement. Gives us a continuous monitoring of endotracheal tube placement and effectiveness. So if we had good waveform, we had good exchange, and now we don't, that could tell us that our tube is actually displaced. Either it's went right mainstem bronchus, or it actually has withdrawn and we no longer are actually in the trachea. And then it checks the effectiveness of the cardiac compressions. If we are doing good compressions, and we should see the end-tidal CO2 come up, hopefully. If we're doing poor compressions, it kind of tells us whether we're doing good or bad. It is a first indicator of return to spontaneous circulation, and that's actually even before a pulse or a blood pressure is noted. And it says moderate low perfusion, early signs of shock. So the person may be a trauma patient, we start using the end-tidal CO2 on them. They're bleeding in their belly, and we can't understand they don't have any respiratory compromise. They seem to be breathing okay, but their capnography is crappy. That could mean that they're actually bleeding in their belly, their thighs, whatever. So we can use it for hyperventilation patients, hypoventilation, asthma patients, and COPD patients. Gives us a clinical course of action, any kind of changes in treatment, and then it lets us trend. So when we start trending on the monitor, it kind of gives us a general idea if we were doing good, doing bad, if we kind of just plateaued, or we kind of just flattened it out. All right, so oxygenation and ventilation, what is the difference? So you think about that, what's the difference? Oxygenation, ventilation, really, is there a difference? There actually is a huge difference. Remember oxygenation, okay, it's two different complete and separate functions. Oxygenation is the transport of the oxygen via the bloodstream to the cells. So the oxygen is required for the metabolism. Ventilation is the exhaling of the carbon dioxide via the respiratory tract. So carbon dioxide is that byproduct of metabolism. So oxygenation is the transport of O2 via the bloodstream to the cells. Ventilation is us actually getting rid of the carbon dioxide. That's why we talk about, retaining CO2, which will give you a very high CO2 rating, versus blowing it all off and you'll have a low CO2 rating. All right, so pulse oximetry is, oxygenation is measured by pulse oximetry. It's percent of oxygen in red blood cells. A change in ventilation can take minutes to detect, and it's affected by motion artifact, poor perfusion, and some dysrhythmia. So I think everybody has had that patient that you just cannot get a good pulse oximetry reading on, whether due to nail polish, it's bumping down the road, just them fiddling with the pulse oximetry probe, whatever. Now, ventilation is measured by the end-tidal carbon dioxide. Partial pressure, so basically millimeters of mercury or volume of CO2 in the airway at the end of exhalation. It's a breath-to-breath measurement, which provides information within seconds. It doesn't matter if there's motion, artifact, poor perfusion, or anything else. It's not affected by it. Once again, it actually tells you if you're perfusing or not, if you have a good perfusion, when you are studying the ventilation or the end-tidal CO2. So the respiratory cycle, oxygenation, the oxygen is inhaled into the lungs and carried into the blood, versus ventilation, where the carbon dioxide is transported back from the blood to the lungs and exhaled. All right, remember that end-tidal CO2, it says it reflects changes in ventilation, so the movement of air in and out of the lungs. Diffusion, which is the exchange of gases between the air-filled alveoli and the pulmonary circulation. And then perfusion, which is circulation of blood. So end-tidal CO2 reflects the changes in ventilation, diffusion, and perfusion. So monitor your changes in ventilation, diffusion, or perfusion. So ventilation, so for asthma, COPD, the airway edema patients, the foreign body airway obstructions, or stroke patients. Monitors the changes in pulmonary edema patients. So for diffusion, pulmonary edema patients, alveolar damage, CO poisoning, or carbon monoxide poisoning, smoke inhalation. And then perfusion, that's shock, pulmonary embolus patient, cardiac arrest, or any kind of severe dysrhythmias. All right, so the capnographic waveform, the normal waveform of one respiratory cycle, is similar to an ECG. So the highest shows the amount of what the end-tidal CO2 is, and that length depicts the time. So when you're looking, this is actually, this right here is at full expiration. So when they exhale, that is CO2 at its highest. And that's what we're measuring, is actually that point right there. Okay, so for the capnograph waveform, the capnograph detects only the carbon dioxide from ventilation, no carbon dioxide present during inspiration. So when you're taking a breath in, that is right here. So as you're taking the breath in, it's this. Okay? All right, so there's 4 phases. We got the baseline. Phase 2 is the ascending phase. Phase 3 is the alveolar plateau. Phase 4 is the descending phase. So you can see all those phases if you look at the look down at the bottom of the picture. You can see phase 1, phase 2, phase 3, and then the descending phase, which is phase 4. All right, so during phase 1, it's dead space ventilation. It's the beginning of exhalation. There's no carbon dioxide present. The air from the trachea, posterior pharynx, mouth, and nose. There's no gas exchange occurring there, and we call that the dead space. The ascending phase, that's when carbon dioxide from the alveoli begins to reach the upper airway. It mixes with the dead airspace. It causes a rapid rise in the amount of carbon dioxide. The carbon dioxide is now present, and it's actually detected in the exhaled air. All right, phase 3, or the alveolar plateau. Right now, we have carbon dioxide-rich alveolar gas. This constitutes the majority of the exhaled air. Uniform concentration of the end-tidal CO2 from the alveoli to the nose or mouth, or the carbon dioxide from the alveoli to the nose and mouth. And then phase 3, it's the end of exhalation, contains the highest concentration of carbon dioxide. That's actually what we're measuring, is like the end-tidal CO2, the number seen on your monitor. So that is right here is what we're measuring. This is what we're hoping is 35 to 45 millimeters of mercury. And then phase 4 is that descending phase. So basically, it's the inhalation begins, oxygen fills the airway, carbon dioxide level is quickly dropping to 0. There's our normal range, 35 to 45. So there's a normal waveform, looks pretty good. All right, so let's think about this. How would your waveform change if you intentionally started to breathe at a rate of 30? So the frequency. Okay, so obviously that's going to increase. The duration is going to shorten. The height, what do you think is going to happen to the height? So the height should be going down because we're blowing off all of our CO2. And then the shape is going to be very narrow, and it's not going to be as wide. Okay, so if you look there, get the normal ventilatory rate. So increased respiratory rate, decreased end-tidal CO2, rapid respiratory rate, it'll start to narrow down a little bit. Duration starts to shorten, and then eventually our end-tidal CO2 will go down. So if we decrease our respiratory rate, so this would be like our cardiac arrest patients, or this would be our overdose patients, any overdose patient from like heroin or a sedative, will have a normal. The slower the respiratory rate, the higher the end-tidal CO2 is going to be, because they're retaining all that carbon dioxide. So you can see in the top picture there, the top waveform, that's fairly normal. You know, probably 35 to 45, let's say. Like, we'll just split the difference, say 40. The respiratory rate, once it slows down, so the duration is going to decrease. So we actually are going to have very prolonged plateaus. And then, once again, we're retaining, all that CO2. We're not able to blow it off. So that's when our end-tidal CO2 is going to be like in the 50s and so on. Okay, so here's the differences in the two. There's increased respiratory rate on the top, decreased respiratory rate on the bottom. So increased respiratory rate, you can see that it kind of starts getting smaller versus that decreased respiratory rate with an increased carbon dioxide level. So the hypoventilation leads to respiratory acidosis. Hyperventilation leads to respiratory alkalosis. Okay, so this is basically what they call shark finning. It says uneven emptying of the alveolar gas alters emptying on exhalation, produces changes in the ascending phase with the loss of the sharp upslope. It alters the alveolar plateau, producing a shark fin. COPD may see a dip in the middle of the plateau, and then emphysema may see a gradual decrease in the plateau versus a slight increase. You've got a decent picture right there at the bottom of the bronchospasm or the shark fin. Let's see what that looks like. That's just the incomplete emptying at the end. Alright, so using capnography in the intubated patient, or when we're intubating, or after we've intubated. So that's where we hook it up onto our LifePak 12 or our 15. Doesn't matter which one, but that's where we hook it up to. This is when we're using the filter line. So traditional method of confirmation, listen for the breath sounds, observe their chest movement, auscultate their stomach, we notice any kind of tube clouding. We make sure that we visualize the tube going between the cords. And at the bottom you see where it says these methods are subjective and unreliable. Essentially, like for breath sounds, yeah, I think I hear them, I'm not sure. Chest movement, that may be a big chest movement before, it may not be a big chest movement. If I don't know the patient that well, I'm never going to know that. Auscultating their stomach is not a good reliable source. Sometimes you can't hear anything in their stomach. Sometimes, essentially you'll listen to the breath sounds, you'll actually hear in the stomach, and vice versa. Or you listen to the stomach, you hear breath sounds. And then noting the endotracheal tube clotting is just not a reliable source as well. Alright, so it says confirming the endotracheal tube placement. You can see the picture there on the right hand side. Basically, they've got hardly any end-tidal CO2. They give them a good breath. They start blowing off that CO2. They have that incomplete emptying, and then it will get the big shot of end-tidal CO2 or CO2 that blows off at the end. It also tells us what our placement is in the esophagus or in the trachea. And it says endotracheal tube placement in the esophagus may briefly detect the end-tidal CO2 following carbonated beverages or ingestion of beer, and when gastric distension was produced by mouth-to-mouth ventilation. The residual CO2 will be washed out after about 6 positive pressure breaths. So after 6, whether 6 breaths with a BVM, it actually should blow off and wash out all of the residual CO2. Okay, it's a pretty good picture for hypopharyngeal dislodgement or the ETT displacement. Getting good waveform, and then all of a sudden it just kind of peters out there, and that's essentially what it does. It displaces the ET tube. There's no cellular exchange, and then obviously not being able to ventilate the patient, you're not able to blow off that end-tidal CO2. So there's an esophageal dislodgement. You can see that it's normal, then all of a sudden it just kind of flatlines out. For us, documentation or the trending gives us an ongoing documentation over time through the trending printout, and the documentation of the correct position at the emergency department arrival. So what you don't want to do is not call the hospital, not tell them what's going on, and the next thing you know, they're all sitting in the D station or they're sitting in the doctor station, not paying attention while you roll in with your patient. So make sure you paint a good picture for them. All right, so capnography and CPR, remember, it assesses the effectiveness of our chest compressions. No matter how big and burly and strong you are, they say that if you don't change chest or people within about every minute to 2 minutes, you will actually go down in your chest compression depth and quality. And this will actually tell you whether you're doing effective chest compressions or not. Definitely an early detection of return of spontaneous circulation. And our objective data is for decision to CC efforts. So basically all of that information collected together gives us a good indication. And if you call the hospital and tell them that you've got a patient that hasn't, their end-tidal CO2 has been 10 the whole entire time, you dumped XYZ medications in them, you've oxygenated them, you've done this, you've done this, you've done this. I'm not going to speak for them from a percentage standpoint, but if I had to guess, I would say it's, in the high 90s that they're going to tell you, just field term. So, good relationship between the end-tidal CO2 and cardiac output. A decrease in end-tidal CO2 reflects a critical reduction of cardiac output. A low cardiac output reduces the blood flow to the lungs, and it fails to clear the end-tidal CO or the CO2 from the bloodstream. All right, so we talked about rescuer fatigue. It says rescuers were not able to maintain adequate chest compressions for more than 1 minute, and rescuers did not perceive fatigue even when it was measurably present. So this OCHA study, basically they hooked a machine up, let everybody do compressions. They noticed that after a minute, their chest compressions, just no matter how big they were, they started losing the depth and the quality. And then obviously the rescuers not perceiving fatigue. They didn't think there was any kind of fatigue until they told them, objectively, you got this report, you're doing crappy chest compressions. All right, so an increase in end-tidal CO2 has been shown to correlate with a fresh rescuer at a faster compression rate, new rescuer during CPR with no change in rate, and then mechanical compressions. There are some local departments that actually have the mechanical compressions. They're very, very nice. They're just very, very expensive. All right, so you can look at that bottom EKG. You can notice that it's a very low end-tidal CO2, and then progressively it was getting better. And that could be because of your chest compressions. So basically, if you're not doing good chest compressions, it's going to remain low versus doing good chest compressions, checking your, make sure that your tube's in the right spot. Essentially, what's going to end up happening is, your end-tidal CO2 is going to increase to where you want it to be, in between that 35 to 45 range. Okay, so just a quick study. It said they did a study of 90 free hospital patients that were intubated in the field. Out of those 90, there were 16 survivors. And 13 of those survivors, a rapid rise on the end-tidal CO2 production was the earliest indicator of return of spontaneous circulation. So that was even before they were able to palpate a pulse, and also before they ever got a blood pressure on the patient. All right, so if you detect any kind of return of spontaneous circulation, briefly stop your CPR, check for an organized rhythm, and then get back onto the chest if you need to, or you stay there and just monitor the patient. All right, so decision to cease efforts. It says capnography has been shown to predict the probability of outcome following resuscitation. It may be used in the decision to cease resuscitation efforts. All right, so the maximal level. So anything less than 10 millimeters of mercury during the first 20 minutes after intubation was never associated with return of spontaneous circulation. So out of those 90 victims that they did the study on, they had 100%. They're unable to get their end-tidal CO2 above 10 millimeters of mercury after 20 minutes. All right, so we're going to go over ICP a little bit. Remember that for suspected intracranial pressure, what our treatment goals are, we want to try to not necessarily lower the ICP, we just don't want to get any worse. So we want to avoid cerebral hypoxia, which means we monitor their SpO2. We make sure they maintain an adequate cerebral blood flow. So if we hyperventilate them, that's going to end up constricting the vessels. Constricting the vessels, they're not going to get the blood flow to the brain that they need. All right, so high level of CO2 levels, that induce the cerebral vasodilation. So it's positive increases in the cerebral blood pressure to the counter cerebral hypoxia. And then a negative would be the increase of cerebral blood pressure, increases the intracranial pressure, and may increase the brain edema. The hypoventilation retains the carbon dioxide, which increases the levels. So low CO2 level can lead to cerebral vasoconstriction. So in other words, that's a hyperventilation. We hyperventilate them, we blow off their CO2, and that's going to lead to that cerebral vasoconstriction. So end-tidal CO2, about 25 to 30 millimeters of mercury, causes a mild cerebral vasoconstriction, which may decrease their ICP. So decreased ICP may not cause or increase in cerebral hypoxia. Hyperventilation decreases the carbon dioxide level. So if you have a very high CO2 level, you can hyperventilate the patient while you're monitoring them to make sure that the end-tidal CO2 does not get below 35. All right, so for the non-intubated patient, typical call, trouble breathing or shortness of breath. All right, so for the pediatrics, we use those anytime that we've got a kid that's under 44 pounds. For the adults, we use it for anybody that's above the 44-pound range. So adults get 44 pounds, kids are below 44 pounds, as opposed to the colorimetric. All right, so what is it? Is it asthma? Is it bronchiolitis? Is it pulmonary embolus? Is it CHF? Is it just cardiac ischemia? Is it emphysema? What is causing this? So we got to kind of dissect a little bit. So non-intubated patient. So ventilation, airway obstruction, could be a bronchospasm, any kind of airway narrowing, any uneven emptying of the alveoli, or any kind of mucus plugs. So asthma, COPD, airway edema, foreign body, and stroke are all the things that we're looking for the non-intubated patient for airway obstructions. Okay, so from a diffusion standpoint, any kind of airway inflammation, retained secretions, fibrosis, decreased compliance to the alveoli walls, COPD or chronic airway modeling, and then the reverse airway disease. So pulmonary edema, alveolar damage, carbon monoxide poisoning, and then smoke inhalation. All right, so bronchospastic conditions. So the air is trapped due to the irregularities in the airways. They have uneven emptying of the alveolar gas. It dilutes the exhaled carbon dioxide. It's a slower rise in the carbon dioxide concentration during exhalation. We have an uneven emptying of the alveolar gas alters emptying and exhalation. This is back to that shark finning. It says produces a change in the ascending phase with a loss of the sharp unslope, and alters the alveolar plateau. All right, I'll let you look at this slide real quick. Essentially, we look at the symptoms, so breathlessness, talking, alertness, respiratory rate, accessory muscles, wheeze, pulse, the partial CO2, saturated O2, CO2, and our position when we find them. So, patient that's walking, they're talking complete sentences, a little agitated but not completely agitated, increased respiratory rate, no accessory muscle use, I'm not going to go through this whole thing. I was just looking a little past it. Sorry. For us, the biggest thing is, just be aware. Be aware that, the patient, one, can deteriorate quickly. Two, if you find them in that, moderate or severe stage, make sure you prepare yourself for, an imminent intubation. Secure that airway, control it. Okay. So here's the normal EKG, normal capnography on top, waveform on top, and then the bottom is that bronchospasm for somebody with like an asthma, COPD, so on and so forth. So that's obviously exaggerated, the initial versus the after therapy. All right, so we get called for a 72-year-old female who is complaining of shortness of breath. She has a history of coronary artery disease, congestive heart failure. She's a smoker, and she has COPD. She's got a productive cough. She's got a recent upper respiratory infection. Her pulse is good. Her BP's up a little bit, and she's tachypnic at 27 respirations per minute. All right, so what are we going to do? So we get an initial capnogram of that on A. So without the treatment, that's what we're going to get. You can see that he's got supraclavicular, he's got the sternocleidomastoid, that's this one right here. Got the supraclavicular, trapezium, so basically all this is sucking in. He's got that suprasternal, so, and then this is what we want it to look like once it returns to normal after treatment. We're hoping. Okay, so now we get a CHF case scenario. We get an 80-year-old male. He's complaining of shortness of breath. Got a history of 2 MIs in the past. Always on oxygen at 2 liters per minute. He's got a pulse of 66. Blood pressure's good. Respiratory rate is 36. It's labored and shallow. Skin's cool and diaphoretic, and he's got 2+ pedal edema. That's a bad day for him. His initial SAT is 69%. Woo. And his end-tidal CO2 is actually 17. Alright, so we place the patient on non-rebreather mask at 100% oxygen. Give an IV diuretic, which we don't do anymore. We definitely give him sublingual nitro per our protocol. So 10 minutes after our treatment, their SAT goes from 69 to 99. And his end-tidal CO2 goes from 17 up to 35. So there's no doubt that we fix this patient. Alright, so for hypoventilation. Get an all mental status. So whether it be sedation, alcohol intoxication, drugs, strokes, central nervous system infections, or head injury. Not breathing as fast, which in turn, because you don't breathe as fast, you end up retaining the carbon dioxide. You retain that, it makes you very ill, and you become acidotic. So it's best if you do leave your gear, if you have a habit of it, is get up an hour early, put it away, and you won't have this problem. Alright, so with the hyperventilation, it says end-tidal CO2 is above 50, and its box-like waveform shape is unchanged. The shape is unchanged. So for us, we observe a caller call 911. We find a 76-year-old male sleeping unresponsive on the sidewalk. He's got a gash on his head. He's got a known history of hypertension and alcohol intoxication. His pulse is 100%. Blood pressure's up at 188/82. Respiratory rate is normal. SAT's in the crapper. It's 69% on room air. Alright, and you can see it's just incomplete emptying. It just looks like a bad EKG. Okay, so we get a 57-year-old male who was involved in a motor vehicle collision. He's got an injury to his chest. He has a past history of atrial fib, and he's on an anticoagulant. He's unresponsive. His pulse is 100 beats per minute, and it is irregular. His blood pressure is 88 over palp, and he is intubated on the scene. Alright, so we get the 72-year-old female who is complaining of sharp chest pain and shortness of breath. Her legs are swollen and the pain in the right calf following a flight from Alaska. So ding, 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 ding. It's a problem. Her pulse is 108 and it's regular. She's got a respiratory rate of 22. Her blood pressure is 158/88, so it's high. And her pulse oximetry is 95. So, we got strong radial pulses, a low end-tidal CO2 is seen in a decreased alveolar perfusion. So for DKA, typically we'll see a rapid rate in normal waveform, and an elevated end-tidal CO2 is seen here. That's not typical, however, it does happen. And it says it's seen as an early respiratory compensation for DKA. So it's not, I can't say it never happens, but it's very, very rare for that to happen. Being able to tell if somebody's in DKA from an end-tidal CO2. All right, so an elevated baseline says oxygen mask probably is not tight. They have a poor head and neck alignment. The shallow breathing is just not clearing the dead airspace. So if you see that, where their SAT's kind of crap, or I'm sorry, their end-tidal CO2 is kind of crap from a waveform standpoint, there's big gaps. Tighten up their oxygen mask. Make sure their head and their neck is aligned. Make sure that they're breathing hard enough, and so they can actually get rid of all that dead airspace. All right, so here's our end-tidal CO2. You can see here what it looks like. Pretty high. But this is our line for 50. We're probably at 48, 49, and it doesn't look like it's too much better. It's an overdose. So this is what it looks like after Narcan. And we went from a range of 50. Now we're at 40. Here's 30. So, I'm sorry, 35, 45, 50. So, you're looking at probably 38, 39. So, that's pretty good. All right. So, that's the end of this lecture. And it is now time to take the quizzes. Thank you.